the clinical trials were designed to support FDA approval, which was, in negotiation with the FDA around an anatomic endpoint, which was the growth of geographic atrophy on fundus autofluorescence. So the clinical trials weren't designed, and therefore, you would select a very particular patient population if your primary goal was to show the visual acuity or some other visual function benefit. So, for example, in Derby and Oaks, 2/3 of the patients enrolled already had foveal involving GA, meaning the central, the very center of the retina was already atrophied with loss of the RPE and overlying photoreceptors. So that's not probably a great population to show a functional benefit in. And you might choose a different population if you really wanted to focus on functional outcomes as your primary outcome. Now, that being said, in the Oaks study, microperimetry was done. And microperimetry, although it didn't really show a benefit at the 2-year time point, when you actually look out to 3 years of treatment, there was a benefit in terms of the two pre-specified microperimetry endpoints, which were overall retinal sensitivity and the number of scotomatous points. Now, those of us, as we've learned from Derby and Oaks and other trials, the lampalizumab trials most notably, those are probably not the best microperimetry parameters to use, because if a spot starts in the atrophy, that's a scotomatous point at the outset. And so nothing's really going to change there. We're not trying to reverse GA. And similarly, if you have a spot that's far away from the atrophy, well, probably in a 2 or 3 year time point, the atrophy may never hit that spot. So probably the most relevant area anyway, if you were going to design a test that was primarily for, showing the functional benefit, is in that junctional zone at the edge of the microperimetry. And you might argue, and I think Apellis here in the Derby and Oaks and Gale's data now have made a rational argument that maybe the central 4 or central 16 points, those are the most critical real estate. And what is the kind of likelihood of all 4 of those points going to 0, basically no sensitivity in either the central 4 or the central 16 loci? And here is where we really see about a 35% reduction in the patients who received 4 years of treatment versus 2 years. So it's a 30%, 35% risk reduction of developing all 4 of those central points becoming scotomatous, and very similar data for all 16 of those central points becoming scotomatous. So there is evidence of a functional benefit. It just took longer than the 2 years of Derby and Oaks as the, to manifest itself. And of course, as I said at the top, the trials weren't really designed primarily to show a functional outcome. They were designed to show an anatomic outcome because at the time, that's what the FDA asked for.